Good morning, ladies and gentlemen. I never speak to people whose teeth I have never seen. They are too dangerous for me. We do very stressful jobs and we frown. That's why I have this here. And these things take different shapes all the time. So when you find a moment to rest and smile, please do that and rest your face. If you happen to have no teeth like me, just show them where they used to be and smile. My name is Paul. My surname is Swatu. Difficult surname, but if you forget, call me Satu, call me Sowetu. My white colleagues call me Swartz. I'm used to it, so I'm never offended by what I am called. I don't become what people call me. My 5-minute role this morning is to say a heartfelt word of gratitude. You might not understand why I interrupt your program. It is because I really want to express from the depth of my heart how grateful, how thankful I am that you have left your patients, you have left your desks with all paperwork to be done. You have left important meetings for the day, tight deadlines and plenaries for the World AIDS Day, build-up activities, and you chose to be with us. On behalf of the board of this organization, on behalf of my CEO, on behalf of the team, I want to heartily thank you. I don't take it lightly that people of your caliber that are holding the lives of our people in their hands can really take us this seriously when we send you this invite and really show up. I need you to give yourselves a round of applause for that. My title might not be an OPM, but when an OPM respects an invite from an organization like ours, I take my head off because it tells me about the condition of the heart of that OPM. I am more impressed by what the heart speaks than what the outward person says. And for that, I want to really thank you. Tulwana Emilimo supports you. Its mandate is to make you shine in your own facility. With everything else that we have, with everything else that we are, ourselves together with Free State Rainbow Seeds as implementing partners in this district, our business is to make you shine. And if you have anybody around you whose business is to make you shine, you look after that person with whatever you have. Secondly, we have no place and no role taking over your facilities. Instead, it is our business to make sure that your facility becomes the most performing facility. Thirdly, you have a huge responsibility of holding us accountable in the sense that you have key indicators of performance in the program that you are implementing to assist this facility to reach its own targets. Sit us down, call us to your meeting and say, as an organization, we are missing this, that, and the other. These are the resources we have committed. This is our commitment as the facility. But we do not see a movement in this particular space. Not only that, sit us down and say, we're seeing the following gaps in our cooperation. How do we close them? I'll make a perfect example. Sister, please stood up so that the people can saw you. Run up front if you can. Casper, please stood up so that the people can saw you. And Sister G and Sister Rampuan, please stood up, colleagues. Stand right up here. I'm going to make a statement that I will not regret once. These are professionals. They are not Tulwana nurse, they are not Free State Rainbow Seeds nurse, they are professionals. Their status is as equal as any other professional nurse in the facility. And none of them, and I'm speaking with authority, None of them will walk into your facilities and service the clientele that they are servicing and leave your clients in a long queue. If that happens for no reason, I am the first person to know that your nurse that is supporting me in the facility comes in, attends to his 2 clients, leaves my facility with long queues, yet this is a professional. It will not happen, it cannot happen. If that happens, let me know, and I'll give you my direct number. The reason I'm raising this is because these colleagues cannot walk into your facilities and walk on eggshells because they might be treated as orphans in the facility. Yet they are professionals. So we are pleading with yourselves, let's hold hands together and support each other. The clients that they are servicing and bringing to your facility are actually your clients. They are not our clients. They are the Department of Health's clients. I have taken an issue with Dr. Mkwena and said to him, Dr. Mkwena, we need the Department of Health in this municipality to come to the party and support us. If we are pulling to this side and the department is pulling to the other side, the person suffering is the beneficiary, the client on the ground. So I hope that this message is clear to me, to my team, and to yourselves, colleagues.
Day, what we should take away, what we should go home with, what we should talk to others that are left behind and explain to them, to say, this is what the reason I went to that workshop, and this is what I have learned. We are going to, at the end of this training, it is important that the institutions in this house understand and knows the people who are their partners when it comes to LGBTI community. Specifically for today, transgendered clients, who are the people that when you are facing a certain challenge or you can't explain something to them, who are the experts, the partners that knows better. So you will know them already. They are displayed. There's Rainbow Seeds and there's Tulwana Emulim. Those are the ones we have around Mangau. At the end of this training also, we need you to understand the specialized services when it comes to transgendered people. There has been complaints we will hear that they are not being treated in the correctly. So there are specialized services that are directly linked to them. So we will at least know them, and we will also understand who are these transgendered people, so that you do not just put one blanket on everybody, so that you understand when we are speaking about MSM, we are speaking about this kind of person. When we're speaking about a transgendered person, when we're speaking about just a gay person, or because Muslim in one pot. Hey, transite. That is what is happening, the corridors. Okay, and then we will also get information about gender affirming healthcare. What exactly is gender affirming healthcare? I'm sure they've been coming to your facility asking you to say, I need this kind of service, and then you have no clue what is that and know how to refer them. So we will be learning about gender affirming healthcare, and also in primary healthcare, where in your level of primary healthcare, where these processes start, exactly what is it that you need to be doing, your roles in primary healthcare when a client who is a transgender comes in. So these are some of the information that you are going to back to your facility having, understanding, as you would have asked questions so that they are explained clearly. And you are in a position also to disseminate the same information to other people, other staff members, so that at least your facility becomes an LGBTI-friendly facility, not just by name, but also the behavior and services that you are offering. Any questions up to so far?
Friends, how do we classify them? The LGBTI. The other thing is how to consult an MSM client. Yes.
Suppression of hormones and
Suppression of hormones.
The hormones issues, because the other ones want their breast actually to be big, and the other ones want to suppress
Hrt.
Existing policies covering this LGBTIQ and transgender population.
Existing policies.
How to give support to, I'm not sure where she was, but she was a lesbian and she was pregnant and she was angry and bitter. You know, I didn't just know how to get it there. If you could get me support to get in there.
Diagnosis of LGBTI and MSM at an early tender age.
How to diagnose?
Going to know whether it's a she or he. When maybe I'm addressing her, or maybe she's greeting me, or yes, how am I going to say Dumela Tabo or Dumela Ubuntu, because I'm used to say Dumela Dati. Hey, how am I going to know say she or he?
My name is Hrt Referrals. I'm from Beyond Zero. I'm a trainer. Thank you.
Oh, thank you.
My question here will be, how can health workers, including teachers, support the LGBTI students? I hope I'm clear.
Yes.
Thank you.
Very clear.
Specifically, psychosocial. Yeah, if there is an established system, yeah, so that we know where to refer.
Doing PrEP in our clinics. So I just want to know which lens should be given PrEP, actually which one, because it seems as if everyone is coming for PrEP.
It doesn't go. They reject them. They don't accept them. They didn't talk about them. The community. How can you involve through councillors meetings, such as community meetings? We educate the community. Don't discriminate, so that they're even afraid to come to the clinic. They know that somebody in the clinic. They know that what. Okay.
People with this Hrt address for the person, Hrt address for client. That you don't make them more uncomfortable to come to get service at the clinic.
That's our child. My expectation, it's mostly from our colleagues, that we don't box up our LGBTQIs and say, give out to one. There are people from Joanna, they are Joanna clients or they are Rainbow Smith clients. I should not walk into an institution and then find people saying, colleagues saying, as I said, you're here for your people. Again, we are there to provide a service to all our clients. So I'm not expecting to hear, I sound like I'm bullying now, but I'm not bullying. I hope that we come out of here knowing that the LGBTQI are all of us are responsible for them.
In 2005, a group of 4 women sat together They looked at the situation in this country in a very small town, Tabanj, West Plateau, say, our kids are not working. Our kids are just falling into drugs. Our kids are just loitering. They are not getting opportunities for school. As mothers, we really have to do something about it. These women were from church. They decided to say, next weekend, we are ascending a mountain to go pray about this situation. We cannot. They went. This is the story I'm told. They went to the mountain. They came back. On their way back, they had the name Tolwana Emolemo in their heads. So these were the founders in 2006 of the organization Tolwana Emolemo. This is where we were born. This is where we are working. So Tolwana Emolemo is an NPO that was established in 2006. Its main purpose is poverty alleviation, is training and development, where we provide skills for not only young people, ordinary individuals, young women, so that we can combat the unemployment and poverty. We provide a variety of healthcare services. So upon our working and functionings, then we saw another space where there was a lot of discrimination and injustices. That's when we entered the LGBTI space. So now I'll talk only about the services that we give within health space and LGBTI space, because this workshop is mainly for that. We offer HIV testing and counseling for overall, all the people, but our prioritized clients would be the LGBTI community. You will be explained, like if you asked this LGBT, what does it stand for? There are experts that will be coming to stage to explain all of that. We also do Hrt Referrals. It has been a journey to us from getting to where we are when it comes to Hrt. I'm sure the sisters in here, they know the frustrations behind when a TG person comes to your facility to say, I want to start hormonal replacement. You don't even know what to do. We do support groups. We know the modular support group has always been an evidence-based model. We use IACT and other materials that we have, so that at least we bring people, we empower people in their own spaces, whether they are HIV positive, whether they are negative, whether they are victims of rape or crime, and then we do the TB screening and STI screening. They are full package within HTS. We cannot do one thing and leave others. And then wellness clinics. Basically, our job is to make sure that everybody is well. Our educators, they will run their own wellness workshops. Our professional nurses will go teach the community on wellness mentally. Our social workers will work on psychological effects and then health advocacy. Like our media liaison person said, she's an advocacy officer. We also take forth issues within LGBTI space. Really, we see that government or civil society or communities, or they are not really looking into this, and then we just push forward the mandate to say, let everybody's human rights be respected. And then psychosocial support, you just mentioned as part of the expectations, we offer psychosocial support. We have social workers, and the Desatu made us stand as nurses. So Lena bullying, our other social worker is not here, but let me list the other one. There's our social worker.
Already heavy. Like for example, I'm a transgender person and I don't want to be referred to as a she. I see myself as a he. And I want all that to be seen and everything else to align with who I am. Then I go to Home Affairs and I want to change my gender marker. Then I get problems because of the discrimination, because of the legislation. So you see, together with that, we also have our healthcare services that are poor, that are giving poor services to transgender clients. So now, what she highlighted here was that there was a doctor that they interviewed at Steve Biko Academic Hospital, whereby he was saying they are having services, these reproductive health services at their institution. And then because now we find that our clients, before they want to transition, at Steve Biko, they give them an option to say, okay, we are going to transition, meaning you are going to introduce foreign hormones to your body. Now that can affect your fertility. So before you go through the process, you have an option of saying, maybe we can freeze your sperms, maybe we can freeze your eggs, so that in the future, if you want to have your own biological children, you have an option to can say, yes, I can have my own children without feeling bad that you went through the process of transitioning. So they offer those services at Steve Biko. We once went, I can't remember if my colleague, my colleague is here, whom I went with at Universitas Hospital. We know that we do have fertility clinic there. So I went for a research to find out, okay, this is Steve Biko, this is Gauteng, other provinces, but now what is happening in the Free State? Because we cannot be saying rely on what is happening on the other provinces. So we went to research and find out what is happening in the Free State, because some of our clients would be saying, in the future, so now what about us? And that information, we also need to disseminate it to the primary healthcare services. So because our clients, the moment they hear that you are now trans friendly, they will come and ask you, now what do you do? How do you refer me? Where do you refer me to? So now we went to the fertility clinic, and then when we went there, services are there, but they are paid for. So it's unfortunate that most of our clients are not even employed. So they have to pay for the services, but the fees are not that bad, but they will be bad for somebody who's unemployed. The problem currently is that they do not have the machine to freeze the sperm and the eggs, the ovaries. So now they said we were relying on donor funders from, I think, cancer with that machine. So the machine is problematic at the moment. So Free State, we don't have the services at the moment. We don't know until when. So for I know it's not a nice thing to say to a client, because we are supposed to be providing services. But the reality is that for now, we don't have these services. But in the country, we do have the services. Okay. And then now we also saying, remember, our clients, when they, Dr. Zozo said, when they go to their services to go and access or to go and ask for services, they would find that some of us, I would say us, because healthcare workers, the attitude that we give to the clients, and like I said, sometimes lack of knowledge, lack of understanding, it will lead you to that. Or sometimes it's just our attitude. It will lead me to saying, you are looking at this beautiful young woman who enters your facility, and after looking at her, you are always saying, Dumela Ausi again. But now when you're looking at the ID, you are seeing a different story. I remember when in some clinics where we went to sensitize, we talked about this, where we're saying our expressions would be saying to the client, these people are not aware of transgender people. Because now this is whereby you'll be like, Marie, okay, Some people would go as far as saying, hey, umunnamos. Yeah, some people would literally say, hey, umunnamos. And that is offensive to a client. So we need to find a way, we need to learn ways of saying, if you see something that is a bit different to, you are reading this and then you're looking at that and then it's different. Maybe we need to find a way of saying our composure should be different, it should be professional. Actually, we should be professional enough to understand all the dynamics that come with transgenders, with any other client, whether disability, it doesn't matter. So they also had those challenges, but they have learned that they needed to educate their staff. They also educated their clients that the staff didn't know, but now we have educated them. Now we are having services. Okay, so now there are also other options that they, when it comes to Steve Biko and the services that they offer. They also offer surgery at Steve Biko. So you will get to understand later on when we unpack the process of transitioning, that there are processes, there are steps, there are options when it comes to going through transitioning. So basically, here we were talking about freezing the eggs. I've already spoken about that. They have that option. They also have the option of saying our clients can go for surgery, whether it's top surgery, whether it's bottom surgery. Those will be explained a bit later on. So all those services, they are being offered as Steve Biko, but when it comes to Free State, yet again, it's a problem. It's yet again a problem because we try to go again and research and find out what is happening at universities, because previously, the doctor that I met told me previously there was a doctor who was doing top surgery, like removing breasts. But currently they are complaining that they don't have specialists who can do the surgeries. But amazingly enough, you come as an assigned female at birth and you're having lumps, you're having cancer, but now there is a process of you removing, you have access, you can remove your breast, but funny enough, when it comes to a transgender man who says, but I don't recognize this, I want to transition, I want to remove this, then it becomes a problem. It becomes a problem. You are being told that there are no specialists. So that is also an advocacy issue that we are going to be going into, we are going to be talking to, and then to make sure that eventually our transgender men who want to go through a top surgery, they can get the access the service, because we know if we can remove my breasts that are having lumps, they are not different from the breasts that are transgender men. Right? But bottom surgery is a bit complicated. It needs a specific, specialists. We don't have them here in Free State. We don't have them. So those are, at least, the most important thing is for us to be equipped enough to can say, let me sit my client down and say to the client, these are the options that we are having in the Free State. We are not saying in the future they won't be here, but for now, this is what we are having. And to make things easy for ourselves, remember, just to give yourself time to sit down and say to the client, but this is what we are having. It's enough to the client to say, but it means our professional nurses or our clinics, they are aware of us. They are aware what is available for us at our area. So that is more than enough, because if they are managing to listen to what we are saying in the organizations, they will always also be able to listen to what the nurses are saying. Why can't I want to do today what? Because if I say this and then you say that, you know what they do? They will never want to go to the clinic to access services. They will always say, I will never go back. I State Rainbow City, I will never go back. And remember, the model said we need to link. Because NGOs are not there forever. But primary healthcare services will always be there. Right, so now to the interesting part. I know there is an expectation on this part as well. This is what we are calling the LGBTQIA plus terminology. So we cannot continue with our training without taking this first. Because when you go to the clinics, all people who are assigned male at birth and they fall under the LGBTQIA plus, they are all gay. I get that is what. Eh, apere mo se ke gay. Asa wa bara ke gay. Ha fela ke na no roke wo no tola le bontati gay. Ne. But that is not how it is. So now we are going to learn the differences between who is who and how do I end up when I talk to this one, how do I address this one? All those are dynamics. Okay, right. The very first letter L, it stands for lesbian. That we know. Okay. If I may ask, sister, how did you identify that your client was a lesbian?
After seeing the way she was dressed, I think, because I didn't expect time, but, oh, sorry. I could see by the way she was dressed. She was just coming to ask for something, but I just saw an angry young woman, you know, a bitter young woman, you know, who was, I think she was asking for her file from my department, but the way she was dressed, I think that's how I identified her.
Okay, so when you eventually talked to her, did she say she was a lesbian to you? Okay, so there's a possibility that she was just expressing herself in a particular way, but she wasn't necessarily a lesbian. That is a possibility.
She is interested.
Or she's a clinic client, you know her that she is a lesbian. Okay. 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 All right. So with the lesbians, what we need to understand is that lesbians are not women who want to be male. They are not women who want to be men. They are women. They understand that they are women. They acknowledge that they are women. That they were. Oh, when Scalp school, okay. Okay. So lesbians are not pretending to be men. They don't want to be men. They are women. Men. And they acknowledge that they are women. The only difference between a lesbian and a cisgender woman who is heterosexual is their attraction. So a lesbian, okay, sister.
I'm asking about the lesbian. Are you born being a lesbian or I can make myself a lesbian?
Present themselves, I get. So now these women, they are still women. They acknowledge that they are having breasts and these breasts are mine. I don't have a problem with that. It's just that I like expressing myself like a bit more masculine. So I get it. Back then we would have you'd find them they seldom wear dresses. They will only wear dresses when they have to go to church or when they have to go to funerals. I get. Right, so that the dress up code is just an expression today. And then we have a bit of those that are a bit feminine. Don't look at me, and then you hear that I'm a lesbian. Doesn't make me any less of a lesbian. Doesn't mean I'm not lesbian. If I'm attracted to women, I'm attracted to other women. I get. So those are called feminine lesbians. Okay, then we go to gay. Gay men, they are also men. They are still acknowledging that they are men. Even when they go to toilets, they will tell you, I have a friend of mine who would tell me, or who is gay, and they will tell me, I'm not confused when I have to go to the toilet. When I see a male figure, I know I go there. I get, because, yes, that when they are not confused because they are not identifying themselves as women. They are men. And if this is a male toilet, I will go to a male toilet. But I'm attracted to males. I am not attracted to women at all. My physical attraction and my emotions are towards other men. So with gay men as well, we have categories. With gay men, we're having what we call masculine gay men. And with masculine gay men, it's sometimes not easy to see that they are gay until they tell you that I'm gay. I get even book some books crush say how papa so one as my boyfriend. So we have those masculine gay men. Usually we don't see them unless we see them with their partners or unless they tell us that they are gay. And then we have feminine gay men. Now, with feminine gay men, there are gestures that are giving away, or maybe this guy is gay. So they're a bit softer than your typical guy. You would see sometimes Baba was clean too much. I get sometimes the way they are talking. I get that. Sometimes the way they express themselves. You'd find that they are dressed like men, but Baginya Manala sometimes. Sometimes they put on makeup, even though it's not a lot. Sometimes they put on eyeshadows. Yeah, they can do that. That is just an expression. That's how they are expressing themselves. But they are not less of a men. They are still men. Everything about them says men, and they are okay with it. Okay, now we go to bisexual. Bisexual, bisexual people are sometimes even ridiculed, even in the LGBTQIA plus space. It's like they're confused. They don't know what they want. Because they are attracted to both men and females. Yes. So maybe the woman that you were assisting is also bisexual. That is also a possibility. Maybe she's not a WSW, but a bisexual, because bisexual person is attracted to both sexes, whether male or female. We are able to be attracted to both. And then remember, with attraction, I use the word attraction a lot. It's not only about sex, because the moment we say attraction, then we're thinking sex. Relations as well, because it says we have sex with both men and women, but you can also have relationship, long-lasting relationship with this person. If you are bisexual, you can get married to another woman if you are a woman. And then when you divorce, you can get married to a man. It's not only about what we do behind closed doors. And then we also have transgender. So this one is the one that is more interesting. Okay, before I move on with gay men, there's a question about bottom and top. Yes, that one is very interesting, and I don't know if when I explain it, will I not be insensitive to other people's feelings? Oh, we are all messed up.
Can I say something?
Yes, ma'am.
Yeah, concerning, I like this topic a lot. I like this topic of bottom and who is top, who is bottom. What we usually say, sister, to our colleagues, we usually say to them that they shouldn't offend other people and ask them who is top, who is bottom. Don't go into their bedroom, because they don't come to our bedroom. They don't ask us how do we have our sex. So why should we ask them how do they have their sex? So they can be versatile. The other one can be bottom today and then tomorrow he's top and all those things. So we usually don't go that deep unless if he comes to the clinic presenting with an STI. It is then that we are going to ask how do you have your sex. But other than that, even with lesbian, we don't ask who is a man, who is a woman. We don't go to their bedroom because they don't come to our bedrooms. Thank you.
Okay. But for the purpose of this training, because we need to understand the dynamics that comes with being versatile top, bottom. Because like sister, you are saying, you need to understand our clients, the way they are having their sexual activity without going to their bedroom. I get also bottom about top. But if you know that, okay, this client is a gay man and is saying Because what they usually say, I get about the clinic, they're not saying sister, so they are saying it's STI. They come with a diagnosis most of the time. So now it's up to you as a professional to probe and find out what are the symptoms. Why are you saying whatever you are having is an STI? That's what we do. So now if you don't know the type of sexual activity that occurs in the gay relationships, it's not going to be easy for you to find out where are the symptoms. Yes. So when it comes to the bottoms are the receivers of penetration. Yes. So we know that in gay relationships, in most cases, anal sex is preferred. Yes. So the receiver of penetration in anal sex, then you say that is a bottom. So it gives you, if now the client comes and says, I have an STI, then it gives you an indication of to say, should I now go look at the anus or is it the penis that I should be looking into? Now you are open-minded. Because if a person who is present is an assigned male, comes to the clinic and says, another STI, the first thing you're thinking is the front. No, we never think of the back. So with this knowledge, now you can be open-minded and start thinking, okay, maybe I shouldn't be here, but rather there. No. So with the top would be the person who is penetrating. Then we would know that the one who is penetrating who has signs, it means it is here. And now the interesting one would be the versatile. Both penetrated and they penetrate. No. So that answers our top and bottom, and we added versatile. No. So you know that when it comes to gay clients or gay patients, you need to explore all the avenues, all the areas where sexual intercourse takes place. Okay, so where were we with transgender? Okay, with transgender, this is where now our core, what we are talking about today. Transgender, I would read it as it is, then you go into it. These are people, either male or female, but live opposite to the sex that we were born with. This person, when you look at them, they are female. I get it? But now the way they are living, the way they express themselves, the way they see themselves, is opposite to what is here. So that is a transgender person. If now this person was assigned male at birth, we said baby boy, I get, and usually we are the victims as nurses. We are being told that we are the ones who are giving babies their sex at birth. I get about the saying taking, I don't wanna, and that's not us, because what we do is we ask the mother. I get midwives. Are we saying your child is a boy? No. We are not saying that. We give the mother a chance to say to us, what are you seeing? Then the mother will say, now I see a boy. And that child didn't say they are a boy, né? They were just born. We didn't say the child was a boy. As midwives, as doctors, we didn't say that. So we are not guilty of that. As the child's mother, we would say the child is a boy. And then the child grows up. And they realize, but I'm not a boy. Who said I'm a boy? Because when I look into the mirror, I see this beautiful girl. And the mother said, I'm a boy because they saw the genitalia again. So the mothers usually are the culprits. So with a transgender person, it's very interesting that we see them at a very young age. Very young age. Some of them, you see them at 3-4 years old. The way they are expressing themselves. I get. Hey, you see, or you usually say, I want to see boy, what's about walk it home? I get. I get. Because you find that if they are assigned male at birth, they prefer being with girls all the time. They are playing with girls. They see themselves as girls. Toys. Sometimes they play only with girl toys. Sometimes they would play with whatever toy is there. Ne? But you would see their preference is more towards the opposite of what they were born with. I get. So those are transgender clients. And then when they reach puberty, now this is where now the hormones are picky. And when the hormones are peaking, behaviorally, the first thing what happens, attraction. I get they at 13, 14, now they start seeing, okay, njolo. And then what they do is they do what they are attracted to, I get the person that they feel. And in most cases, not always, transgender people would be attracted to the people of the same sex. When we're talking about sex, we say, I get the organs. In most cases, highlight that one. It's not always, because then we have transgender people who are attracted to people of the opposite sex. But we are going to unpack that later when we explain the differences between the sex, the sexual identity, the gender identity, and sexual orientation. Okay, and then we come to the word queer. So with queer, these can be a gay person, a lesbian, a transgender person. As long as this person is under the spectrum of LGBTQI, they can call themselves queer. But most people who prefer to be called queer are those that we are saying are gender non-conforming or non-binary. They are like using the word queer. So these are the people who are saying, I'm neither male nor female. I get. I don't recognize a male, female genders, or I'm both. So we're having people like those that are using the pronouns that are a bit difficult for most people to use, because I get when you look at the people, the person you would expect to say she or he. I get. So with non-binary people, they will tell you, if you want to use a pronoun, rather say them or they. So how easy it is to say, when you're talking about Sister Gwedashe, you say they, Sister Gwedashe, they. How easy is it for us to say that? It's not easy, but it's doable with practice. The moment you learn and you are willing to understand it, then it becomes easy. Yes, I also still struggle a bit with them and they. I still struggle a bit, but because we are in a learning space, we get to understand and we get to avoid offending our clients. Okay, and then we also have the intersex. With intersex, I would like to engage a bit with midwives. Have you, in any of your deliveries, encountered an intersex individual? An intersex baby with ambiguous genitalia, both female and male. Sister, have you encountered that?
I was saying I have seen that while I was at Elevon Hospital. She was having two sexes. It was the vagina and then the penis. And then what the doctors did, they only wanted to see in which side is she having a womb or what. Mm-hmm. Yes. They only did that, but I don't remember whether something was removed there.
Okay. Yes. That is an interesting observation. Some of us who only saw it very textbook. Mm-hmm. Yeah, we've never seen it live.
Yes, currently I do have such a baby at my institution.
Okay.
And he's busy with a university special.
Okay, interesting with how you are dealing with this child named sister. So how are the parents Gary? Is the child being seen as a boy or a girl, dressed like a girl or boy? What is happening?
It's still a baby.
Oh, it's still a baby, a small baby.
Small baby.
Okay.
But the mother seems to understand. She's following.
Okay.
What's actually going to happen with the child.
Okay.
Because in the very same story that they said, they are still waiting for investigations. They did something, and she is going for the results, whether she falls in this or in this.
Okay. All right. So when are you? Okay. So in instances like this, we've seen that previously when we look at research is that medical professionals will give advice and say the child's having a womb, or let's remove this, and then maybe the parents would say we want a girl child, and then they keep the female genitalia and they.
The penis was not that well formed. And then along the way when she or he was growing up, the mother was buying dresses for him. And then he grew up like that, and then the mother passed on. And then when he reached the age of 12, 13, he was with the grandmother. The grandmother was buying trousers, boy clothes, saying that when you're not a girl, you are a boy. And then the grandmother died. He was left with the uncle. The uncle said that when you are a boy, you must go to the mountains for circumcision. And then they took the child to circumcision, and then we don't know what happened there, but the Gobela or the Musue or whoever there, after they performed the operation or whatever, he came home. No, what happened? He said that you are not a boy, you are a girl, and then he cut off the penis. And then he went home. Along the way, when he was growing up, this child started to have some complications. And then he went to the hospital, and then the doctor, when they checked, because he was still having a womb, they discovered that along the way, when they were cutting that penis, something went wrong. They had to remove the uterus, and they had to do total hysterectomy and oophorectomy. Now, this lady, because now he doesn't have a penis, but he's still having a vagina. Now, he wants to have a relationship. He doesn't have a womb. He doesn't have a penis. He doesn't know where he belongs. He was angry with the father. He was angry with the mother. He was angry with the uncle. He was angry with the grandmother. And then, most unfortunately, the uncle also died. So this child was attending the psychosocial support because now he was angry with everyone because he didn't know where does he belong. Is he a male? Is he a female? Or what happens? So that's what Sister Gwadashi is saying, that you leave the child until the hormone kicks in, and then you will know where does your child fall.
This is your reality at clinics, because we are moving away from saying these services should be from NGOs. We are moving away from that. We are saying all the primary healthcare services, because monitoring is something that can happen in primary healthcare. Hey, some of them, they will bring a prescription that can easily be dispensed at the clinic. Because now, like for instance, Sister Webinar, at Webinar, you cannot be expecting a transgender woman to be traveling all the time to universities to come and collect. So it is the clinic's responsibility to say the Hrt Referral comes to us, we order for you, and then you come and collect until such a time it is your time to go for follow-up. So Hanzaka Tonka Primarine at your clinic, and then you start seeing these breasts developing. Now you are saying this is not the same person. So you have to prepare yourself. So the answer would be this person, but that is one part of the answer name, because we're still having this part that says identifies heterosexually. What does that mean?
They see themselves as heterosexual, but now we can't say that for them.
Yes, but let us define. When a transgender woman says, I'm a transgender, how can it Okay, let me just try and explain first, then you can answer. What we need to understand is that we have deduced that this person is a transgender woman, because this person was assigned male at birth. We saw the picture before they went through the transitioning, and then we saw the picture after, where now this person is a woman. Now, identifies as heterosexual. That part, let us try to explain it. What does that mean? We're not saying we're going to see it from the picture. We are saying this person has told us that they are identifying as heterosexual. What does that mean? What do you understand by that? Yes, it's myself.
Okay, now the way I understand it, I get that guy was a man. Is a man actually. Now he has transitioned to be a woman. So now, as a woman, to be heterosexual, she has to be with a man. That's how I understand it. I don't know if I'm right.
Okay, your answer is partly right and partly not so right. Let us start with the first half of your answer. This guy, this man, was a man. You see what we should be moving away from as healthcare workers. This person was never a man. A transgender person has always been who they say they are. So this person, the wording that we should be using, this person was born a man or was assigned male at birth. Then in that way you are saying you are moving away from giving this person an identity. It's like this person had this identity, now they're moving away from this identity. So what we need to do, we need to be careful of the wording that we use as well. Because as you said that with transgender client in the space, maybe the training will be concluding by now. So we need to learn the correct words to use. So this person or this human being, you can say that, was assigned male at birth, has always been a transgender woman, and then took it upon themselves to say, okay, it's time to transition, I want to align myself. Then they transitioned and they became this person that they have always been. It's just about transitioning, it's all about just aligning yourself to your identity. Now, this person, after identifying, they say, okay, now because people are not going to question whether I'm a man or I'm a woman. Now I can fully say I'm a woman. Who do I date? Then you date men. Maybe this person has always been dating men. But it becomes easier even to the community to say this woman is dating this man. Hence we will say their relationship is heterosexual. So do we understand now the dynamics? The section, chapter 2, section 9, it talks about equality. All of us, we have equal rights. So as much as your rights are important, the rights of the LGBTQI are also important. And then the last, you stick to the problem at hand. At consulting, we have spoken about that one. And then our task is to make sure that we're going to teach our junior staff. And when we do this, I'm going to ask, let us not focus on the nursing staff only. Please, because now most of the problems, they are now starting to come from the security and from the clerks. The clerk, sister, if you're not aware of it, the clerk, the clinics and bedroom. Because what they do, you are in the consultation room, you don't know anything. And as far as you know, your clinic is friendly to the LGBTQI. So, but now you don't know. Your clerk said to my client, we cannot open a file to a 16-year-old who is on ARVs, matric student, who doesn't have any time to come to the clinic. At 2:45, then your clerk would say, I am not going to open this file and give it to you because it's time for me to go home. Yet we are saying we're having youth-friendly services. So these are not the things that the nurses are doing. You are not even aware. that is happening, but it is happening in the clinics. So you can imagine that child, we're not talking PrEP, we're talking ARVs, a 16-year-old who's losing out on ARVs. Then we are saying when they come back and they are not virally suppressed, we are saying Kibona was told, and the child was there. So even the securities, they are starting to have a habit of saying that the file had from 3 o'clock, but 20 people are at 4. I get 4 o'clock. So these are the things that are giving us nurses a bad name, even if it's never about nurses. Because as this moment, air facilitating, it is attached to the nurse. So when we're doing these trainings, I'm going to humbly ask that we include all the categories, even the cleaners, because sometimes the cleaners would assist in other corners of the clinic. So let us train everybody in the clinic, and then we also need to have this IEC material. You know, the moment you have IEC material in your corner, there's a corner in every clinic that has IEC material, or even the notice boards. The moment our clients see these IEC materials, you will see them flocking to your services because they are going to say, this space is friendly for us. It has heavy information for us. You can even ask us as NGOs to say, we don't have anything specific that says transgender. Can you bring us, even if it's a poster that says something on transgender, let us assist you to put it in the clinic so that it can draw our transgender clients to the clinics. And then we also recommend that you partner with us. When I say we're saying partner with us, we are not saying when we are having events, we are inviting you. We are saying when you are having your wellness days, some clinics do that. They call us and say, we are going to have a dialogue at the clinic. We are going to have a dialogue at the community. As the clinic, come and assist us, come work together with us at this dialogue. Remember that unity, it will say to the client and the community, it is not wrong to be transgender because the clinic is teaching us about transgender. It's saying NGO because if it looks like it comes only from the NGO, remember it will still have that stigma. So if it comes as a collective, then it says this thing is there, and then people should start taking it as being normal. And then advocate for institutional policy change. Remember, as institutions, you are able to make those smaller than policy changes. Like body secular clinic arrangement in our clinic. This is what we are going to do with regard to transgender healthcare. So if you start it there, it starts small and it starts working, then we disseminate it to maybe other, let's say it is started by Zebin, and then you see it's working again. Then you start sharing it with other OPMs to say, but we are doing this and it is working for us. Then the whole district starts doing the same thing. Then do you see how powerful that is? It can actually influence those policies that are restricting the services that we are supposed to be giving to the clients. I don't know if we have any questions because I think it's time for me to rest my voice. What we usually do before we even start to refer them, we start by referring them to the social workers. So the social workers are going to sit with them, have one-on-one sessions, maybe 2 or 3 sessions, and then thereafter they are going to refer them to the psychologist or the psychiatrist at a psychiatric complex, and then thereafter they will be referring them to universities for hormonal therapy. And then after a certain period, they will be referred back to us again to the clinics. But it's a long journey, and we need to tell our clients that this is not a 2-month process or 3-month process. It's a long journey to transition. How should our gender affirming healthcare, what is our gender affirming healthcare worker do? They will have a medical record, they will have a hormonal therapy, gender affirming surgeries, and other support.
after everything, if they want to go to Home Affairs to go and change their identities, they need medical reports from the social workers, from the psychologists, from the psychiatrists, and the doctors who treated the clients. They are going to need those, and the supporting NGO, and then they will be going to Home Affairs for changing of the gender marker. The medical records, they need to have 2 medical records which are required to apply for gender marker on their ID documents. And then this medical records can be written by the doctor who prescribed the HRT, that is hormonal therapy, or the doctors who treated the client at the facility, and the local organization. Along the way, when these clients are coming to us, they will be going to the social workers, to the psychologists, to the psychiatrists, and then they will be coming back to like Tulwana Emulim for psychosocial support and their support groups, because they need to attend the support groups, whereby they will be talking their problems, their side effects, and all those things. They need to have their own support group, whereby they are going to support one another, and then thereafter they will be going back to the clinic again. What are the assessment checklists? When they go to the clinic, informed consent. Our clients, most of them, when they come to the clinic, what they usually do, they will say, now I've experienced it in Kronstadt. They will say that, sister, I want, maybe it's an assigned male at birth, and then they will say that, can you give me Depo-Provera? And some of the professional nurses, they give them Depo-Provera without any prescription, without going through these things, without taking history, without doing physical examination, without baseline investigation, without fertility consideration. They just give. Because some of these clients, I guess they know that it is their right to change their identity. So they will tell you as a professional nurse that, sister, it is my right. I want that Depo-Provera because I want to change my identity. Forgetting that everything needs to follow the book. They need to go for a blood, the baseline investigation. They need to be physically examined. Because what the doctor do, because there's this other one, gender assigned male at birth, a client who came to me and then he said that, Merampot, you know what, when I went to that doctor, I'm afraid to go back there. I said, what is it? He said that doctor is checking me thoroughly. He even wants to check where are my testes, where are they sitting, my testes and everything. He is going to check everything. So he's not just going to go to the clinic and then you give Depo and then he goes. No, they need to go for this. And then importantly, you need to wait. This facility consideration. Because the minute they take those hormones, there are so many things that is going to change. Some of them, they are no longer going to menstruate. Some of you, they are going to have breast. And there are those procedures that are irreversible. So we need to take into consideration the fertility consideration, because along the way they will say that now I want my own child. I want to have my own child. And some of these hormones, when they start taking the hormones, you realize that maybe the sperm count is going to go down, and then the gonads are going to shrink. So we need to explain to them about this fertility consideration. The information consent model. We need to information on risk of treatment. There are risks when they take this treatment. There are risks. Some of them along the way. After 3 years, 4 years, 5 years, they'll say that, no, sister, I'm no longer, I don't want this any longer. I want to go back to where I belong earlier on because of the complications, because of so many things. So we need to explain everything thoroughly to our clients. And then we need to give them the benefits of the treatment. We need to explain the reversible and irreversible effects, the impact of reproductive capacity. Hence, I said that the fertility consideration should be taken into consideration. Consent form, very important. With the Department of Health, there is nothing that you do without an informed consent. Because these clients, tomorrow they will say that, nah, I didn't want this. You said I should do it. So they need to write somewhere that, nah, Bejuda Rampuan, I said I wanted this. So that tomorrow it shouldn't be your weight against my weight. You wrote down and then you sign the consent. You have to speak with your client and give an informed consent. The consent must be signed by an individual who has the capacity. You shouldn't coerce the client. You should inform the client thoroughly of what is going to be expected of you. Assessing gender-related history. This history has no textbook, timeline, or predictable narrative. You should allow the client to talk about their gender identity. Sister Gwedashi has emphasized this over and over again. They need to talk about themselves, and you need to listen as a professional nurse. Different. I'm going to skip some of the because it's a long because there are more than 22 slides.
Usually where?
Okay. Assessing gender-related history. I talked about this in here, and then relevant medical history. You ask the client, in your family, are there people who have coronary artery disease? Because some of these medications, they interact with the hormones. Are there people at home who are having deep venous thrombosis? Are there people with embolic stroke, liver disease, pituitary adenoma, or uncontrolled hypertension? Because they need to check this thing first before they even start with the treatment. Uncontrolled hypertension, you know how are these treatment doing? They need to control the hypertension. Even if, I think we have observed when the client is going for COVID-19, if they are having hypertension, they are being treated before they can be given the immunization again. So with this one also, they need to control the hypertension. Uncontrolled diabetic mellitus, they should be controlled first. And then in the family, are there people who are having breast or uterine cancer? Because these are hormones that they are going to take. So they can aggravate the client to have the cancers, right? And then you check if at the families, are there any people who are having the erythrocytosis or allergies? Or silicone, are there people who are using silicone? Or the client in front of you, is he using the silicone? I know that those clients that are expanding their breast with the silicone. So you need to check if they are using the silicone. I cannot remember what do you? Sorry, please. I talked about this family history. Are there people in the family who are having the cancer, the diabetes? I talked about it. Heart disease, hypertension, liver disease. I talked about these things again. And then medicines. Are they on treatment? Are they taking any prescribed medication? Are they on herbs? Because I don't remember what the pizza. We love herbs. because the client will be on hormones. He will be prescribed with hormones. And then we will go to that corner whereby women will buy mango. And then they will go and buy pizza, a cup of pizza. Those herbs. You don't even know when did those herbs when were they cooked? How strong is it? How weak is it? How is it being taken? You just drink. And at the end of the day, it affects our kidneys, or it affects their kidneys and it affects their treatment. Over-the-counter treatment, OTC. I can't know with us black, and good resistance are always there's this symptom and the carrots, and I can't take him out. Hey, so not it. I want those tablets. You see, he's on hormones, taking over-the-counter treatment, taking herbs, plus prescribed medications. What are they doing to the kidneys? What is it good? What are they doing to our liver? Right. Street hormone use. Sometimes ago, Uzalo. Who is watching Uzalo? There is this lady who wanted to transition. Assigned male at birth, wanted hormones. And then he said that those hormones are very expensive. He wanted to go to the hospital. The hospital was way too much expensive. And then he just went to the street and bought whatever he wanted. And then he landed in the hospital. And then he ended at the hospital because of these street hormones. Because they will tell you that my sister, these are very cheap. You can take them. Avoid those that are doctor, they are very expensive. Take ours. They are very cheap, and then they take because they want fast things, because they want to change now and now. So they just take without taking into consideration the risk they are putting themselves in. Right? Do you want to add?
If I may add, when it comes to street hormones as well, we are also being put in a difficult position as professional nurses. Daddy? Oh, I have to stand.
Yes, please sit down. Please make your stand.
Oh, I was already relaxed. I'm saying, with street hormones as well, as Runa, as professional nurses, we are also being put into a predicament because we're getting clients who are coming to our clinics and demanding depot, again, and they demanding feminine trifastal, again. And some of us, we do give them these hormones because you find already they have been getting them somewhere else. And we are telling ourselves, okay, we know that medically doctors sometimes for mental health care clients, they prescribe Depo, so what harm can it do? So we end up giving them, Depo. But we will not only pose a danger to the client because you are going to have to account to why did you give the client that hormone.
Yeah, it's very dangerous because at the end of the day, South African Lesbian Council will also step in. They will step in. Are we still in the same page? So when they take these feminizing hormones, what are the effects? There is going to be body fat redistribution. When is the onset? It will take 3 to 6 months. And then the maximum effect of these hormones to kick in is 2 to 5 years. So we need to tell our clients, we are not going to take these hormones now and then next month you are okay. It's going to take time. And testicular volume, they are going to shrink again, right? Decreased sperm production, it varies with a person, right? And then maximum effect, Leona, is variable. It may be it may be irreversible with decreased sperm. Because if this person can sometimes have sex with somebody else, that person can be pregnant. Maybe, not always. That is why. I'm not too decided. Thinning and slow growth of body and facial hair, detailed. Venous thromboembolic disease. Hence, it is very important to ask if there are people, family history of deep venous thrombosis in the family. Hypertriglyceridemia. With this line, with what? With diabetic mellitus, right? And then it can cause gallstones. It can cause elevated liver enzyme. It can cause weight gain. It can cause cardiovascular disease with other risk factors like hypertensive treatment. And then it can cause hypertension. It can cause hypoprolactinemia or prolactinoma. It can cause type 2 diabetes mellitus, these hormones. So it is very important to take history. If within the family, are there people who are having these diseases? Seldom. Because with this oral testosterone, some of them, I think they are taking alcohol, a lot of alcohol. So they sometimes take alcohol together with oral treatment. And then not all forms are available in South Africa. Here in South Africa, we only use this. We only use this in South Africa. All those others are not here. And then we usually only use the injection. The cream is also available, but is significantly more expensive. Those that can afford, they can buy it, right? But with us here, we only use this. Effects of masculinizing hormones. There's going to be what? Skin oiliness. I tell you this. We are talking about assigned female at birth. Assigned female at birth. We are talking about assigned female at birth. Now they are transitioning to be male sex, right? So what is going to happen? There's going to be skin oiliness or acne. So the onset is between 1 to 6 months, and then the maximum effect is between 1 to 2 years, and then it is reversible. Facial or body hair, detailed, the beards. This one is irreversible. Once it is there, it is there. It is irreversible. And then the onset is between 3 to 6 months, and then the maximum effect is between 3 to 5 years. Scalp hair loss, that is alopecia. It is irreversible. These clitoris, I think they are going to enlarge to resemble the penis, but it is not the penis, but they are going to enlarge. So the onset is between 3 to 6 months, maximum effect is between 1 to 2 years, and then they may be irreversible. Vaginal atrophy. This vagina is going to atrophy, but it is not going to just vanish into thin air. But it is going to atrophy. 3 to 6 months, maximum effect 1 to 2 years, it may be irreversible. Deepen voice. Once abua kaput, it is irreversible. Whether you stop the hormones or whatever, that thick voice. Reshakumu. Risk factors. Have you observed that? They smoke a lot. So if they can stop smoking, they can reduce high risk of getting these cardiovascular diseases. Family history, and then we should counsel on risk modification. Thorough bind their breast. They say binding means using tight clothing or bandages to flatten one's chest because they don't like this breast, right? It is usually done by assigned female at birth clients, may be done by assigned male at birth patients who have started to grow breasts but need to hide them, right? So, unsafe binding, what do we mean by unsafe binding? Some of them, they use elastic bandage. Some of them, they use flat wrap. Flat wrap, those that we use in our kitchens, right? They use them. Yellow, that we use at home, they use them. Some of them, they use that tape, this. They use this. And then this can be very dangerous. Why? Because the risk factors, they can restrict breathing. They can do muscle damage. They can do chest wall deformity. If they bind this every time, you'll find that there is this deformity on the chest, right? Right. And then those bandages, if they are being too tight, they can break these bones here, and then they can damage the lungs. Yes. Right. Safe binding methods. They can use the chest binders, or they can use multiple sports bras, or they can use layered clothing, or they can use athlete compression shirts. Right? The precautions when using this, they say not too tight, smaller isn't better. They shouldn't take too tight chest bindings, right? They must be able to breathe comfortably. And then they start with short period of use and build up. Maybe today they'll take an hour or two, tomorrow they'll add the hour, and then maybe they will add. Not from the onset, they take a long time when using these chest binders, right? They say not longer than 6 to 8 hours at a time because they can have a problem with breathing. Touching. Actually, we talked about hormones. We talked about this breast binding. Now we talk about tucking. What do we mean by tucking? Tucking refers to hiding the genitalia so that they are not visible beneath tight clothing. If we can see our transgender women, when you see them here, they are very flat, and they will be having these tight trousers. What are they doing so that we shouldn't see their genitals? They use this tucking. They tuck. What do they do? They push the genitalia back in between the legs and secure them with tight-fitting panties. They take this, they bind both the so about paint. Bishop, my hip. My hip. Or they are going to push these genitalias back into the inguinal canal. They take these testes, they put them back into the inguinal canal. Again, we have observed when the testes become did hang so. Have you observed when these people are afraid? What happens to those testes? They shrink again. Where do they go? Where do they go? Back into the inguinal canal. So this time they are not afraid. They are pushing them. What are they doing? They are going to lift testes up to the scrotum and through the inguinal ring. They say it is easier if laying on the back Medical tape can be used to secure the scrotum. Especially made gaff can be used. This is the gaff. Or the other one, when we were in Joburg, they say that instead of using the medical tape, they use the sanitary pad. Right? Just to secure. Right? And then, this is how they do it. They push it up to the inguinal canal. Right, but I can repeat them. They push them up into the inguinal canal. Precaution. It is easier if shaven. You go slowly and stop if pain, nausea, discomfort occurs. If they feel nauseous, they stop immediately. And then they should be very careful when they sit, because they shouldn't sit on top of those scrotum. Right? You know what, sister? You were saying?
I was saying, usually our transgender women, they like joking and saying they are on their periods. Ne? So they would be asking each other, do you have a pad to borrow me because I'm in my period? They don't literally mean they are on their period. They just mean that
it's necessary, not cosmetic. So what are they doing? They can do top surgery, they can do bottom surgery or other surgeries. Right. With top surgery, what are they going to do? They're going to do mastectomy. Right? Or they are going to do augmentation mammoplasty, or they can do both procedures, usually done one after the other. Right? Baseya matswele assign female at birth. Assign female at birth patients after 1 to 2 years on hormones so that natural breast growth is maximal. That is assigned male at birth. Assigned female at birth patients, they can be done sooner. This is when they are going to remove these breasts. Should I continue?
Yes.
Right. So that was the they do here. They did facial feminization surgery. They did tracheal shave. They did vocal cord surgery. And then they do pectoral implants. I talked about silicone. Can you remember? I talked about silicone implants. So they do that, pectoral implants. Or they are going to do other aesthetic procedure for assigned female at birth and assigned male at birth. That is having a discharge. You ask questions according to what has been assigned at birth. Even if he can be a male, you ask questions according to what has been assigned at birth. And it is very important for this assigned female at birth to do regular pap smears because they're still having the uterus. It is very important. They still need to check their breasts if they didn't do the breast surgeries. With assigned male at birth who are still having the penis, you still have to do the kind of visual testing. PCA, PSA. You still need to do PSA because they can.
Of October, just now, the doctors have seen the need for us in South Africa to have our own guidelines that are assisting us when it comes to offering gender health care services. So in this, you will find the content of particularly the second presentation. You find everything in here. You have your tagging, your binding, it's in here. Your hormones, the changes that happens, it's in here. I made sure that all of us have a copy so that our facilities can use these to refer in case that we have forgotten what to expect, what to explain to our clients. And the other thing and then you also have the knowledge to can say, okay, the process of transitioning, it goes like this. You don't just say, I'm going to refer you to Turan. But you sit with the client because the counseling starts with us. Sister Bejuda already mentioned that when it comes to counseling, it's not only for psychologists, it starts here because we are the ones who are on the ground with the client. So we are able to explain to the client that what you want to go through, this is what you need to expect. So blue one, is it blue or green? Blue. And yes, we understand that you are a woman, but now giving this client a pink file, you are doing injustice because now the content of the file doesn't correlate with the client's anatomy. So the best thing to do is to sit down with the client. We teach our clients to explain to the client that the design of our files, it doesn't say we do not recognize your identity. You are still a woman, we respect that, we understand that, but because you are physically you were born or you are assigned male at birth, what we need to do, what the nurses need to do or to work on is on the content, I guess. So if you explain, I found that I also had a problem like that, but I found that when you sit down and explain and you say, like for example, you said we have to do PSA. Where do you record it in the pink file? No way. No. So for the purpose of recording and keeping our records correctly, we explain to our clients the purpose of having the different colors of the files. I hope I explain.
Are we done? Are we okay with that one?
Yes.
And then number 2, who is top, who is bottom?
Yes.
Are we okay with the meaning of LGBTIQ age plus?
Yes.
How to consult an MSN client?
Yes.
Right. Referral institute and support?
Yes.
Where do we refer them? Where do we refer them? Acronym HRT? What is it? They're being abused and they're being raped. Let me make an example. I'm not going to mention name. Here is a lesbian friend with a gay guy. They are very, very close friends. They were from the tavern. They were working towards home. And then the community around them, they knew that this one is a lesbian, this one is a gay. And then what did they do? These boys, they came, they said that to this lesbian, you sleep with her in front of us, or else we are going to rape you. He had to do it. But after doing that, they raped both of them. That corrective rape. Do you see that trauma? It was very traumatic for this gay man to sleep with her friend forcefully, and then thereafter they were raped by this gay. It is very, very, very traumatic. They are being harassed, they are being discriminated, right? How to identify LGBTI at an early age. You did cover that, no?
Yes.
You did cover that. Was it covered? At an early age? At puberty?
Yeah, it was.
It was.
It was covered.
It was covered. Risha. How to destigmatize LGBTI? If I say to you, like Ibrahim, are you going to say to me, Marunan Maswef? Go to the system. They are being judged at the gate. So when they come to our clinics, already they have answers. So we need to know how to deal with them. And another thing, right? This thing of saying LGBTI community, it bogs them. We shouldn't say we are a community of straight people, and then there's a community of LGBTI. We are all people, right? LGBTI people, right? Psychosocial referral.
This is not directed to you alone, but directed to all of us.
Yes.
Is a criminal who attends to a child facility. Is any criminal that walks into a healthcare facility receiving help that any client that walks through that door should receive? Is any drunkard that walks into the facility needing assistance from that facility receiving the assistance that she needs? This goes to my third question. Is the LGBTQI person who walks into that facility receiving the same kind of support?
I usually say this after giving my presentation. All of us, we are having the watches, like watches. And what is having WATCH, right? I get. So what is the meaning of this? W say we should watch our ways. Always, we should watch our ways. Going to spread the STI, they are going to spread HIV, right? So we should watch our attitude. We should watch our thoughts and our tongues. What we say might break or might make the client. We should watch our thoughts. We should watch our company. We should watch our company always. Every time when I'm sitting with Sister Wedashe, Kamoti timing, and then every time we are blabbering about Sister Mamang, and then we don't talk positive things, we are not going anywhere, and we are not doing justice to our clients. The last age, we should wash our hearts. Let's feed our hearts with good stuff. If it's possible, let's feed our hearts with the Lord's Prayer every time before we touch the client. Because those are human beings. So before we do anything, let us wash ourselves so that we can give quality services to our clients. Thank you, Chairperson.
In this presentation, I'm just blown by the name, Tulwana Emodem. You guys, you are not even aware that all the members of your organization, Kidi Tulwana, and Kidi Tulwana Emodemo. Well done. This is not the first presentation that I've attended or a workshop. The last time we had a visual one, and you always raise the standard. To all the health workers that are here, let us go back to our sites, to our facilities. These are baby steps. It's not going to be easy because we are also clouded by our own beliefs, by our own values. But we are professional enough, right? What I really love about the presentation was look at the client, don't judge, provide a service. How wonderful is that? Tulwana Mulemo, well done. Once more, raise the standard. From my side, from the Zero side, thank you so much for all the presenters and to all the attendees today. Thank you so much.
Thank you, Dade. I'm gonna start firstly, okay? In response, also one of the responses, one of the OPM. You know, I told you that if you don't volunteer, I volunteer you. So, haki dia masapo, I shebisa kamu. Anshedisa Kamu. Okay, one of the OPMs, just your feedback.
Thank you, Daddy. The thank yous have just been done. I think I'm repeating things that have already been done, but I have been nominated. On behalf of us, the group that came here today, we are very grateful to the organizers of this occasion, and we are proud to be part of it. We promise we won't disappoint. Yesterday, we did not have the empowerment that we got today. Hence, we were not doing things right. But tomorrow we are starting to do things right because now we have the knowledge. I think there's nothing worse than a provider of a service who themselves do not have the knowledge. So today we really are empowered and we are thankful. We are thankful to our presenters. They gave us wonderful content, presented it very well to us. So going forward, we promise we are going to stop putting the Lgbtqia. We were not now to say they are a community. Yes. Yeah, like the patients that they are. They've always been patients, but we just did not know exactly how to handle them. But now we know better. What was also very important that Merampwane ended with, and we will try to do that. But honestly, I hope I'm speaking on behalf of everyone and I say one day did not do this kind of training justice. Well, it's not because we want to stay the longer in the hotel, but yeah. Thank you very much.
Thank you, Mayor. From the experts, anything? Merampwane is done, Sister G. Oh, there's another one. Okay. And I just want to prepare yourself.
I'm sorry to be here and there. I mean, so that the last time previously, when I did this MSM Lgbtqia with an awareness to the community of my area about this Lgbtqia. Guys, you don't know. Only to find I've got a beautiful girl. My daughter is doing 4th year law, and she's a lesbian. And I didn't know that. But the time she disclosed that to me, it was very easy because I've already done it to the people who I didn't know. So I'm just disclosing this to you guys, so that you know that you can be a parent and you don't know. Then when we started talking to her, she said, Mama, this doesn't start at here. It started when I'm in primary. Mind you, she's at the university now because she disclosed that when she was in 2nd year. And how again did we find it? His father bought a laptop, her laptop. He went to the work with it. Then the PA is a white lady, a white lady. Then she used the laptop. Only to find in the laptop, there were female condoms there. Meaning maybe she doesn't have even this dental, what and what and who not, you know. So imagine, how did he find it? Again, that her daughter, beautiful daughter, is a lesbian. So thank you.
I need to disclose before they get to be given service, but I have never had since the morning anybody walk into this room and say, I am male, I am female. It boggles my mind that we expect other individuals, when they walk into their room, to label themselves, and then we can accept them. For your benefit, if this will be any of comfort to you, I am divorced. How about that? How do you feel now? How? Yeah, you see what I mean? Serious. And that changes how you look at me. If I had disclosed this early in the morning, you wouldn't have listened to me. And this is the challenge we have with people and life. I want to wrap up this day by really taking my head off again to all of you health professionals. My one big message today is do not allow one member of your staff to get your facility to be painted with the same brush of irresponsible, insensitive individuals. In our organization, I protect our integrity with my life. The colleagues that work with me, I think you might have noticed that. Have you seen how many of them have been next to me the rest of the day? You know what they were doing? Everyone getting a lap on their back for something. And because they know I do that, sometimes when they do their trainings, they don't invite me. But it is my job. As a manager, you are paid to think. And you think so hard that it hurts. And I have a problem with a manager who cannot think, because that's what you're paid to do. I conclude by taking you religious people to the Bible. You remember the story? Sister G stood up so that the people can saw you. Come over here. Come over here. Please. And do this commitment. If I call tomorrow and I don't get feedback, you are in trouble. You know this lady. You know her. Who is she?
I'm not sure of the name, but I've seen the.
You are fired.
Yes, I will apply again tomorrow.
Yes, apply again tomorrow. Find who she is, find where she comes from, find that background, find that child, supply her with all the incentives and the necessities she needs.
We'll do that.
There's a story about the Good Samaritan. You read the Bible, do you? You remember that story? This beautiful story of the Good Samaritan. It's a parable of the Good Samaritan, which is told by the Lord himself in the Gospel of Luke. So you have homework. I won't give you the chapter and the verse. It is about a traveler who is stripped of clothing, beaten, and left half dead alongside the road. We've talked about all of that the rest of the day. This individual is her daughter. This individual is your uncle. This individual is your family member. And what happens? First, a Jewish priest and then a Levite comes by. Looking into this room, you will decide what is your category and class. Are you a Jewish priest? Are you a Levite? I don't have time to explain these people and their roles and their statuses and their power. They come by. But both avoid the man. I will repeat. But both avoid the man. Finally, a Samaritan happens upon the traveler. You have a choice. Jewish priest, or this other guy, Levite, or a Good Samaritan. I have chosen consciously to be a Good Samaritan. Christian as I am, layman preacher as I am, I have chosen to be a Good Samaritan. And you have joined us today, both organizations, to become Good Samaritans. When good people keep quiet, evil increases. And I'm calling upon you, I don't know how to say this in Afrikaans so that you hear it. May I propose love to all of you. And I expect one answer, to say Yes, yes, yes. Will you please join me, join us, and be good Samaritans to our children, to our brothers, to our sisters. Never for a moment, never is a very long time, think that what you see other people going through with their children and their family members will never happen to you. My younger sister is a police commander in Velco. She's a brigadier. She has a son. And all of us at home, we look at this boy and we have trained ourselves to treat him the same way we treat any other family member. And he has learned to be safe at home, irrespective of what they do. So I plead with you and I thank you. OPMs, please, before you leave, come stand in this corner with me. I need to whisper something in your ears. 1 second. From my heart to your heart. Sister G and Sister Bejuda, I owe you